Speak about the non-glycemic effects of SGLT2 inhibitors.
Thank you, Francisco. Here are my disclosures. So we are all familiar with this algorithm coming from the statement of the ADA-ESD recommendation about the choice of anti-diabetic drugs in the treatment of people with type 2 diabetes. And Francisco just mentioned the need we have to individualize and personalize the choice of these drugs based on the balance between the efficacy and the profile of side effects and also the affordability of these drugs in our countries. So on one side of the balance, there is efficacy. And efficacy actually was defined, which is quite expected in this statement based on the choice of anti-diabetic drugs, was defined on the basis of the lowering effect of HbA1c, the very high efficacy being for HbA1c reduction above 2% and so on. But the authors of this statement were well aware of the need of other markers of efficacy beyond glucose control in type 2 diabetic patients. And in the text of the statement, we can read that glucose control remains a major focus in managing type 2 diabetes mellitus in patients. However, this should always be in the context of a comprehensive severe risk factor reduction program. And actually, we know that behind this statement, there are several reasons. There is a large background. First, we know that cardiovascular risk is always, despite improvements since recent decades, it's always a huge and a major problem with the complication of diabetes, and cardiovascular death is still the leading cause of death in our patients. Second, we must admit that glucose control is still a controversial factor to reduce the burden of cardiovascular disease in our patients. And despite the very recent data from the follow-up, the VADT, for example, in last June, showing that the intensification of glucose control is associated in the long term with cardiovascular benefits, we still don't know exactly what is the effect we can expect in a reasonable time for a given patient to reduce cardiovascular benefit, to reduce the cardiovascular burden just with a leverage on the glucose control. So we need to target other factors. And why do we need that? Because atherosclerosis pathophysiology in type 2 diabetes is multidimensional. And we know that the association with hypertension especially is very common and is one of the other factors we have to target. And this hypothesis is not really new, actually. And a few decades ago, Gade and the co-workers at the Steno clinic conducted the Steno trial showing that a multi-targeted approach worked very well in type 2 diabetic patients indeed, despite the fact that just very few patients had a full hand of the targets reached in this study. The more items you got with this intensification on blood pressure, on the glucose control, and also on lipids, the highest benefit you take from the cardiovascular point of view, and during the follow-up, even for the mortality endpoint. So a multi-targeted approach is required. And what are, from a pharmacological point of view, with a pharmacological intervention, what are the factors that we can expect to touch with a new class of drug beyond glucose control? We may expect an effect, and a beneficial effect on weight, and maybe beyond the effect on weight or reduction of weight, we may expect to modify the body composition and especially the fat distribution to, at the end, modify the cardiovascular risk profile of our patients. We may also expect to modify in a good direction the lipids profile of our patients, maybe acting through the insulin resistance pattern of our patients. We may also expect to modify the blood pressure levels of our patients, and maybe less expected, we may try to modify the kidney function and to preserve this kidney function in our patients, because we know that albumin is a marker of cardiovascular risk, but we know also, and more recently, we are now aware of the fact that glomerular filtration rate is by itself and independently of the albumin excretion rate a marker of risk function. So kidney function preservation at large is also a potential pathway to improve the cardiovascular risk profile of our patients. So looking at all these outcomes with this new class, what can we show finally? So this figure coming from a review by Dr. Knock, published recently, showed the effect for the weight reduction in all the phase 3 clinical trials involving the three main members of this new class, canagliflozin, DAPA, and empagliflozin, with a pattern across the spectrum of diabetes. The drug was tested in monotherapy, add-on to metformin for this part of the panel, add-on to sulfonylurea, add-on to insulin. And in red we have DAPA, in blue canagliflozin, low dose, high dose, and in green empagliflozin compared to placebo in purple or sulfonylurea in yellow, for example. And what we can see from this quite a busy slide is that the effect on body weight, the change in body weight in the absolute values, is quite consistent across the spectrum of diabetes, with a reduction ranging after subtraction to the comparator, ranging from 1 to 4 kilogram during the duration of these studies. And taken globally, last year, Tsapros presented a meta-analysis of all these the studies published so far, and he showed that in monotherapy, but also in add-on treatment, the SGLT2 inhibitors were led to a reduction of about 2 kilograms on the duration of the study. So this is a change that is very consistent across the studies and actually expected from the loss of glucose and calories in the urine due to the mechanism of action of this class. So this is the effect during the trials conducting in the phase 3 development program of these drugs. But what is the effect in the long term, as far as we know, we have the evidence yet? To illustrate the effect, the durability of the effect on weight, we can see here the comparison of dapagliflozin versus sulfonylurea on quite a long term, with a long follow-up after the completion of the intervention trial, up to 4 years. And what is amazing here is that, of course, we have a net difference between the active arm, sulfonylurea, dapagliflozin about 4 to 5 kilograms after 1 year, for example. But what is amazing is the stability of this effect on the weight. And we can remember the similar curves we may have seen with, for example, DPP-4 inhibitors, or even with agonists of the GLP-1 receptors. And usually we had, after 2 to 3 years, a small escape in the curve, in the weight reduction line, showing that, suggesting that the effect of the drugs were lost, at least in a certain proportion of the patients after 2 to 3 years. This is not seen actually with this class, as far as we have the evidence available, and it is quite expected again from the mechanism of action, which is independent of the secretion of insulin, which is declining along the history of diabetes. So a sustained effect on weight reduction. But so beyond this effect on the weight reduction, what is exactly this kilogram lost? What are they made of? This is several trials try to answer this important question, and this one was published already 3 years ago with dapagliflozin, quite short-term, 24 weeks, in people with type 2 diabetes treated efficiently with metformin. And in the control arms, the patients kept just their metformin plus placebo, and in the other arm they received also dapagliflozin full dose 10 milligram. And what we can see is that we have a quite rapid decrease and very early in the weight, and after that the slope was still negative, but a little bit less strongly. And at the end of the study, 24 weeks, the curve did not plateau yet. But actually, rapid decrease in weight, and then a quite regular and stable decline in weight after that. And this was in parallel with a maintained, as Francisco already described, a stable loss of glucose in the urine during all this study. So up to 2 kilograms after 24 weeks compared to the placebo arm. And regarding the composition of this weight loss, what we can see with this panel on the right is that we have a major loss of fat. Fat mass is reduced by about, in absolute values, 2 kilograms, and the lean mass is also slightly reduced, what is expected that when people are losing weight globally. But so the weight loss is predominantly made of fat mass loss. Okay, and where is distributed this fat mass which is lost? This was the answer came from MRI analysis in these patients, and again, what we can see on the right panel at the bottom is that it was quite evenly distributed between the subcutaneous and the visceral depot of fat. So, of course, this last part, visceral depot, was the most interesting, and it is importantly reduced by the drug dapagliflozin in this study, showing first that fluid loss is not the only reason for weight loss with this class of drugs, and then even in quite short term, fat mass, and especially visceral fat mass, is significantly reduced. Is it really significantly reduced? We know, I will not present this data, that insulin sensitivity is improved, peripheral insulin sensitivity is improved with these drugs, but we expect also that lipids may change after this kind of intervention leading to a reduction in visceral fat mass. And is it seen on the lipid profile of the patients? I come back on one trial comparing sitagliptin 100 milligrams to canagliflozin 300 milligrams. What we can see, it was fairly what is expected for triglyceride and HDL cholesterol, with a small here non-significant, but in the meta-analysis, the trend is the same, a small reduction in triglyceride and a significant increase in HDL cholesterol, so reduction of the diabetic dyslipidemia, which is absolutely expected from the improvement of insulin sensitivity and the decrease of visceral adipose tissue. But what was not expected actually was the increase, Francisco already mentioned, in the total amount of plasma LDL cholesterol. This was a moderate, a small increase in LDL cholesterol, for example, 5% of absolute of relative increase in this single study, and this effect was seen in the other studies also, with the other molecules also, and seems to be dose dependent. So a small increase in LDL cholesterol that is not explained and that was not expected, and that is not yet explained today. So what is the net effect on the lipid profile? Actually, we don't know. What we know is just the numbers, and the numbers show that the ratio of LDL to HDL cholesterol is unchanged with these molecules. We know also that the non-HDL cholesterol is not significantly modified with these drugs, and that's it. We do not know anything about the composition, the size of the lipoparticles. Are these LDL cholesterol particles particularly dense and small and so very heterogeneous, or are they on the opposite, large and less heterogeneous than the levels, the absolute levels may make think? We do not know, and this is clearly an area of important research to understand better how this class is active in our patients. So just to summarize this point on lipids, LDL cholesterol is moderately increased, about 5%. The effect on heterogeneity of LDL particle is not known up to now. HDL cholesterol is moderately increased with an overall small reduction in TG, and this is dose-dependent and class effect. And non-HDL cholesterol is usually unchanged in these studies. Third outcomes, blood pressure. What was expected, actually blood pressure reduction was expected due to the osmotic diuresis and the loss also of a small amount of sodium we can expect, at least in the short term. And actually what was seen again in monotherapy, in add-on to metformin, add-on to SU, add-on to insulin, a very consistent pattern of efficacy on blood pressure. This is systolic blood pressure here. The same effect, more or less, is seen, observed with the different members of the class, and very consistent across the whole spectrum of diabetes. So again, dose-dependent effect on blood pressure. What is the bottom line of all the meta-analysis we can conduct on these many trials? Chapras did this for us already last year on in monotherapy, but this is quite the same as an add-on treatment. What we can expect for the systolic blood pressure is a reduction, placebo-subtracted or comparator-subtracted, of about 4 millimeters of mercury with the full dose of these drugs, and this is quite the same as an add-on treatment. So 4 millimeters of mercury is what we obtain with this class, which is highly relevant from the cardiovascular point of view. But it needs to be sustained, is it? Yes, it is. In the same study we already mentioned, comparing DAPA to sulfonylurea with a 4-year follow-up after the end of the intervention study, we have at the end this difference, the same order of magnitude as what we discussed just the previous slide, about 4 millimeters mercury, and with a very stable effect across this duration of the study. So sustained and significant reduction both in systolic and diastolic blood pressure. What are the mechanisms behind this reduction in blood pressure? Actually, in the short term, it's quite obvious. We have osmotic diuresis induced by the loss of glucose in the urine, and there is also a small amount of sodium loss in the urine at this occasion, because SGLT2 is a co-transporter for sodium and glucose, and the inhibition of both components leads to the osmotic diuresis. There is also the weight loss that we can expect to be translated into a benefit on blood pressure. We know the conversion rate is about, for example, from the look-ahead trial, people in look-ahead at 1 year lost about 8 kilograms, and they had a reduction, as a mean, of course, of the systolic blood pressure about 4 millimeters of mercury. So the conversion factor is about 2 kilograms for 1 millimeter of mercury. So there is certainly an effect of weight loss, a contribution of weight loss on the systolic blood pressure. But this is not enough to explain what happens, especially in the long term, because the urine volume returns quite rapidly to the normal values. So this is something else than just diuresis. In the long term, we can imagine that weight loss until it plateaus contributes to the increase in blood pressure reduction. But there are also other factors that may be involved, and up to now we are at the stage of many hypotheses, not being able to rank them between the major ones and the others. But we have some evidence for a reduction in arterial stiffness. This evidence comes from animal studies, but also from a short study by Czerny in the US in type 1 diabetic patient, showing that after just a few weeks we have a modification of arterial stiffness measured by pulse wave velocity approaches. And finally, we can expect also that the renal effect by itself may lead to modification in the long term of the blood pressure regulation, homeostasis. How may it work? We know that in diabetes there is some inflammation in the kidneys. We know there are some modification of the renal hemodynamics, and there are some links between metabolic effect of diabetes itself, glucose into the cells, and these hemodynamic factors. For example, GLUT1, the transporter of glucose, is overexpressed in diabetes, and we know that even in animal models without any diabetes, but with just overexpression of GLUT1 in the mesangial cells, we have a pathology pattern looking just like diabetic nephropathy, just without any hyperglycemia. So this kind of modification of the circuits of glucose into in the kidneys, in the kidney cells themselves, may lead to modification of renal hemodynamics and may lead to renal damages at the end. And with the use of such drugs that modify the glucose handling in the kidney, we may expect that we reduce inflammation in the kidney, and actually it has been shown with animal studies, animal approach, in experimental settings. We can expect also to modify renal hemodynamics, and actually this is what we observed. So all these factors, and maybe other not notified up to now, may act in the good direction to reduce significantly the blood pressure in our patient with this class. What about renal outcomes by themselves? We know that they are likely to be very important cardiovascular risk factors, not just markers. And we of course, the mechanism of action is renal. So we have to be interested by the kidney as a victim or a culprit of hypertension, for example. Here, what we can see in the study comparing canagliflozin, the two doses to placebo, what can be seen for the eGFR in patients who had impaired GFR at baseline, actually, in this slide. So we have a quite stable eGFR during this one-year study, and a quite interesting pattern of eGFR curve early in after the initiation of the study, with a decrease, and this was dose-dependent, as we can see, a decrease in eGFR in the first stage, and then a stable level of eGFR during this 1 year, with actually at the end of the study a very small difference with placebo. And actually, when we know that when we stop, when there is a washout of the drug, eGFR return to higher value. So this is quite a ACE inhibitor-like pattern of eGFR. It seems like if there is an hemodynamic effect actually of the drugs, with an initial drop, maybe linked to a decrease in intraglomerular pressure, and due to change in the resistance of the afferent arteriole in the glomerulus, and then a stable, and we may expect a protection of this glomerulus due to the decrease in intraglomerular pressure. So what it may be, this is an hypothesis, of course, of this my interpretation at this stage. But what we can see is, in parallel, the evolution of the the albumin to creatinine ratio in this patient, quite stable with placebo, but a dose-dependent decrease in albumin, which is totally in line with this effect on intraglomerular pressure. So this is a potential nephroprotection behind this drug, beyond the glucose control, so something specific to the mechanism of action of the drug. And we have some explanation, and this slide comes from a paper by Tierney again last year in Circulation, showing that maybe this effect works through the TGF, the tubulo-glomerular feedback in the kidney. What happens in the normal physiology? There is a reabsorption of glucose and sodium, of course, in the early part of the nephron, but the sodium that goes later on in the distal nephron reach the macula densa, and in the macula densa, sensors of sodium leads to, if there is an increase in the sodium load at this level, leads to constriction of the afferent arteriole to decrease the filtration. Too much sodium in the distal nephron leads to vasoconstriction at the afferent level in the glomerulus to decrease the filtration. So an adaptation mechanism. What happened in type 2 diabetes? In diabetes, when there is high blood glucose, there is an increase of reabsorption of glucose, as we have seen before, but also an increase in the reabsorption of sodium, so a lowering of the sodium load at the distal part of the nephron, and so on the opposite, a vasodilation of the arteriole, of the afferent arteriole, and then an increase in intraglomerular pressure and an increase in filtration. That is one of the explanations of the hyperfiltration seen in our uncontrolled patients. And what happens now with this new class of drugs? We have inhibition of the reabsorption of glucose, but also of sodium. And despite the fact that there are many other channels, of course, that may reabsorb sodium in the, later on in the nephron, we can see that we can expect that there will be again an increase in sodium load at the distal part of the nephron, and again correction of this abnormal vasodilation of the afferent arteriole. So correction of hyperfiltration, exactly what we have seen with this curve of the EGFR. So this is a potential explanation, and we will see if it translates into what we want at the end, beyond nephroprotection, which is a cardiovascular protection, both acting through a reduction in albuminuria, but also a protection on the long term in the renal function and on the filtration. So these are just hypotheses up to now, but there are already two big trials that are ongoing that will test specifically in a large number of patients. First, the effect of canagliflozin on the progression of albuminuria, and second, and most interestingly, the effect of canagliflozin again on the incidence of hard endpoints, end-stage kidney disease, doubling of serum creatinine, or renal or cardiovascular death in more than 3,000 people. So nephroprotection is another potential benefit that will be maybe shown in the next years. Finally, what is the bottom line of all these many aspects of the cardiovascular risk we are targeting? Well, the evidence available today on Monday, maybe on Thursday it may change, but is what we see here. These are the meta-analysis required by the health authorities and put in the dossier of these molecules for the regulatory authorities. What we can just look is a point estimate of this meta-analysis of the clinical trials in the phase 3 programs. The point estimate is below 1, but with canagliflozin, but the confidence interval crossed the identity line, so no increase at least of the risk. With dapagliflozin, the same pattern, point estimate for the MACE, the major cardiovascular endpoints, below 1, but crossing the identity line. And finally, with empagliflozin in the European agency dossier, the summary of data with a low number of events. Of course, this is a limitation of this kind of analysis. Again, a point estimate below 1, and this time it was significant. And as you know, maybe the hottest topic for the current scientific session of the EASD will be the presentation of EMPA-REG outcome trial, and there was a release a few weeks ago claiming that this multi-center randomized double-blind placebo-controlled trial with more than 7,000 individuals with a history of cardiovascular disease, after 3 years, not only showed that empagliflozin was safe, but also reached the superiority conclusion. So it will be an interesting session for sure in 3 days for the detailed results of EMPA-REG. Finally, what can we say for this non-glycemic outcomes with this new class of SGLT2 inhibitors in type 2 diabetes? We have to globally assess and target the CV risk factors of our patients on an individual basis again. SGLT2 inhibition affects several of these cardiovascular risk factors. And first, it leads to consistent and sustained body weight reduction. Although some compensatory mechanisms are very likely because at the end it will plateau, but well, the effect is not at least blunted after 4 years. There are also consistent effects on blood pressure across the class and for various populations, including those with reduced renal function. However, the precise mechanisms of this reduction of blood pressure are not elucidated yet. The effects of lipids are also mixed, and we lack some data on the composition of the LDL particles. And so the net effect is not known, and this point remains a concern for sure. Renal dysfunction is recognized as a potential independent risk factor and may be mitigated by SGLT2 inhibition, and large trials are ongoing. And finally, short-term studies support CV safety of the class, and the first large-scale outcome study claims to be positive, which is a good indication. Thank you. Thank you very much. Now it my